Morning. How's everybody?
Good.
And I believe we are ready to go, sir.
All right. Well, thank you very much. Let's go ahead and get the subcommittee called to order this morning. Thanks, everybody, for joining us. We've got quite a packed agenda of items that we requested after our first meeting. We'll hear from Mr. Jones with an update from what he heard from the sheriffs, Ms. Wicker from the hospital perspective regarding some data and information around the EDs, Commissioner Land on DBHDS and the efforts underway there. Ms. Faison's taking the CTAC report and pieces of it, at least from the CSB perspective, but I really hope we'll dig into that pretty thoroughly as it seems to address not the ED situation, but what we could do to avoid it. And then Ms. Allie Wright and Kelsey Wilkinson on the Virginia Mental Health Access Project. Nice to have you ladies with us. Thank you very much for joining. Is there anyone that would like to address anything or throw anything out as an opening remark before we get started this morning? All right, well, then we will move directly to John Jones, Executive Director of the Virginia Sheriff's Association. Mr. Jones, thank you very much for providing some information from the sheriffs, and you have the floor, sir.
Good morning, Mr. Chairman and members of the study group. Thank you for putting me on first. We've got the sheriff's meeting going on this week, and I've got to prepare for that and leave town, so I appreciate that very much. At the last meeting, the members of the group wanted me to reach out to some of the sheriffs to find out what's going on with the 72-hour period and to get a sense of the drop-off centers, how they're being used and what the reception is. So I did a quick survey of the sheriffs, and we got 19 responses back. It was nothing scientific about it. I think everyone has the raw information in your notebook, but I've got a summary here that I'll talk about briefly and some takeaways. So we asked for information on TDOs for the 12-month period ending April the 30th. So it should be fairly recent for those sheriffs that were able to take time to look it up and report. And there were two key questions here that were asked. And one is, how many TDOs exceeded the 72-hour period in duration? So of those sheriffs that answered, we had 66 that exceeded the 72 hours. And then we asked, why did they go over? And universally, the answer was there's not enough beds. You know, they get the TDO and they're waiting in the emergency room or wherever, and they're looking for beds, and 72 hours ran out, and some of it may be related to a medical clearance. So what happens then if a sheriff's deputy is there with a TDO patient and the 72 hours expires? What happens? So we asked that question, and we found that at least one or two in the survey said, they'd have no more authority, no further responsibility, and they have to walk away. They can't physically hold a person after the 72 hours. And basically, we had some that was treated as reported by the sheriff that answered the survey. Now, that's not always the case. I think what may happen is that in some cases the deputy is there and he can see what's going on, and he just kind of stays in place. He doesn't leave, especially if there's a bed coming up. He stays in place, and then the transportation takes effect. Now, I think there's some liability questions with that, and it depends on how that plays out. But I think that scenario has done somewhat as a result of a public safety concern. So then we went into the drop-off centers, and almost everyone that responded to the question on drop-off centers, they use the drop-off centers. It saves law enforcement resources, and they want to enhance the use of the drop-off centers. Some indicated they needed more staff to expand the hours. And I know at the last report, there was a map passed out that talked about the possibility of expanding drop-off centers in certain areas. And we think that would be good to relieve law enforcement pressure. It would allow those officers to go back to work. So having looked at all of that, and again, you have the data in your notebook, there's a public safety concern, and that is what are we doing to these people that get treated? Now, I don't know how many there are statewide. We only took a sampling here, but the sampling did indicate that law enforcement walks away, and maybe that means a TDO patient walks away. And does it happen all over again? So maybe at some point, someone needs to drill deeper into that. We think that's a public safety concern. We think that all of this indicates, as we've been saying a long time, that there are more beds that are needed. And if we had more beds, we wouldn't be tying up our law enforcement officers. But that's not the major point. The major issue here is what's happening to the patient that's sitting in an emergency room or wherever, somewhere for 72 hours with no service, or with less service than they need. So if there were more beds available, or if funding could be made available to engage private hospitals, that would solve two problems. And the first problem is the patient's needs, and the second problem would be the law enforcement pressure, the takeaway that we're losing from our law enforcement officers that have to sit with these patients. And, some of the rural areas, we've been over this many, many times. When a deputy or two deputies is pulled away, we have to pay overtime, or it really stresses the law enforcement service the sheriff needs. So if we could find more beds, that would serve two problems. It would address two problems. One is the patient. That ought to be primary. The second, of course, is important to us, is the law enforcement. The other initiative I hope that the committee will look at, and we discussed this briefly, is to expand the role of the alternative transportation providers to relieve law enforcement when they are in that situation of sitting for 72 hours or almost to 72 hours. So, Mr. Chairman and members, that's our quick survey and the results and the takeaway from it. And I'll be happy to answer any questions you or any members have.
Thank you, Mr. Jones. So a couple of things to start. Only 19 respondents. We understand when we send these things out, it's another piece of paperwork that people got to deal with. If you're going into your sheriff's meetings, could you just make one renewed effort to continue to collect the data? And particularly if sheriffs have no examples. I mean, if we could clear 40 of them that had none of these examples, that would at least give us some indication. And then others that do, we're interested. So the 72-hour question, maybe this isn't for you, but some of our lawyers can help guide us along. In that 72-hour period, they should be addressed by a CSB and or have a hearing by a judge or a magistrate. Is that correct? So, John, do you have did anybody give you any indication as to how the 72-hour period, what was the issue? Why did the 72-hour period run? Was there not a CSB resource available? Did the doctors in the hospital not have access to a magistrate or to whomever does these hearings in that region? Any thoughts or ideas on that?
Mr. Chairman, and members, my thought on it, and this is a sense, is that there were just simply no beds available. And I think the sheriffs, and if you look at the information on the CSB, on the survey, some of the sheriffs are working closely with the CSBs, and they're coming up with a plan on it. But I think they're looking for beds and can't find the beds.
Right, but I guess that's a secondary question I have. Because there are no beds available, doesn't mean that the patient shouldn't be addressed and have a hearing to determine whether we're going to hold them longer than the 72-hour period, right? Because you could also have that hearing and say, hey, look, you had a tough 48 hours. I'm sorry you've been here in the emergency room. You seem to have been stabilized. You seem to be good. And you can be released because you are not in need of the 30-day TDO. But so I guess I understand the lack of a place to finally put someone in crisis. But what I don't understand is how they're not addressed in the 72-hour period.
Based on my understanding is that they come in on an ECO, and then there is a hearing, and then the TDO is issued, and a bed is supposed to be identified, but they're waiting to get to that process. And sometimes the TDO is issued and a bed is identified, but they are diverted or they are delayed. If, for example, the state hospitals are the beds of last resort.
Right.
And if that state hospital is indicated on the TDO, not said that, we're not going to take them, we're just not going to take them now. We don't have beds now.
Okay. Well, then, Commissioner Land, do you have a thought on that, ma'am?
So my question is I don't think that alleviates the need to have that hearing within 72 hours, which I think is your point. So where are we falling down in the process that we don't still have the hearing, to your point?
Okay, and so that's, John may not know that, but so there's something for us to drill into, right? I mean, whether there's a bed or not, there's a process in place that must be done in a 72-hour window, or as you stated, you have to let the person walk out the door. And so I guess we just need to understand, where were those 72-hour situations and what happened? Maybe it's resources.
Chairman?
Yes, ma'am. Who was that?
Jennifer Wicker with the Virginia Hospital and Healthcare Association.
Yes, ma'am. Thank you, Ms. Wicker.
It's my understanding that those commitment hearings are happening. They're just happening in the emergency department and not on the inpatient unit.
But that wouldn't address the 72-hour crisis we're talking about, right? I mean,
I thought the question was related to whether or not the commitment hearing was taking place.
No, ma'am. You're right. You're right. The emergency doctors that I've talked to in the last couple of weeks, it is happening at the bedside sometimes. Correct. But Mr. Jones is pointing to a 72-hour period that passes with nothing, and therefore, I'm not a lawyer, but I think you would have to let them go.
Within the way that the statute is written, the commitment hearing has to happen within that 72-hour period. So as long as it's happening within that 72-hour period, then the commitment hearing is happening the way that it should be. So I don't think the commitment hearing is not taking place. It just may be taking place with it, up to that 72 hours. Once the commitment hearing happens, then a decision has to be made on where that individual will end up. So maybe I'm misunderstanding your question, but I don't think that the commitment hearing is not happening.
Mr. Jones, can you speak to that?
Yes, sir, Mr. Chairman. My question to the sheriff was, the 72-hour TDO. And I didn't ask what's happening before the 72 hours, and it's probably something we need to go back to, but the question specifically was, how many of these exceed 72 hours? And what happens at the end of the 72 hours? And the answer I'm getting is, some of these folks are being let go and the deputy's walking away, and I think that's a concern. Now, what we need to do to fix it, the sheriffs universally said there was a bed not available, and so maybe the hearing's taking place, and maybe the bed of last resort is being identified. I think we just have to look at the TDO orders and see what's being said and what's happening collectively around the state. But, we didn't drill into it in that detail. My question was, how many of these folks are sitting around for 72 hours? And then what's happening at the end of the 72 hours? And the issue is, the two issues that affect us. And one is the deputy sitting there, or two deputies, and the other is the patients there not being admitted.
Absolutely.
Okay, I understand. So if I may follow up, Mr. Chairman.
Yes.
So with that additional understanding, when the 72 hours has run out, there are situations in which individuals do leave the hospital. However, our hospital members work really hard to work with the patient to keep them at the hospital while they're trying to identify a bed. But technically speaking, after that 72 hours, they do have the right to leave the facility. But more cases than not, our hospitals are able to keep the patient within the hospital setting.
If you had the hearing on site and they determined them to be held for another 30 days, that's not still true, right?
I don't know the answer to that.
Okay. I mean, because still it's not optimal. It's not solving our problem. But I'm just, and maybe I led us down the wrong path here. I'm just trying to determine if we ought to make sure that in the 72-hour window, everyone gets addressed by a case manager and everyone has a hearing, because that's what the law says. And we hope we'd have a bed by then. But thank you. Mr. Jones, you were also on the working committee that did the CTAC expansion plan study that came out in October. Do you and the sheriffs enthusiastically ignore some of the findings there, or how do you feel about that?
I'm sorry, Mr. Chairman, say that again. I didn't catch all of it.
So you were on the CTAC working group that Ms. Faison is going to speak to from the CSB perspective later, as was Ms. Wicker. So I'm going to ask her the same. Do you and the sheriffs come out of that working group enthusiastically supporting going down at least one of the paths suggested for expanding the CTAC services?
Yes, we participated in those working groups. I would need to look back at all of the recommendations to speak specifically to it, but I don't recall anything coming out that we were objecting to. I know that the last meeting of your committee here, there were some suggestions made to expand alternative transportation. We're very supportive of that.
Yes, sir. Well, the key findings were time spent in emergency departments takes law enforcement away from their primary duties. Arrest and incarceration are not the most appropriate options for most of these cases, and services that aid reducing overall number of TDOs in our state hospitals will be of great benefit, which all three seem to be directly on point to our subcommittee at hand. So, so any further thoughts you have from the sheriffs on that in the future, we'd love that. So, any questions? Excuse me, sir. Go ahead.
Mr. Chairman, we totally agree with that. I mean, anything we can do to remove the sheriffs from a non-law enforcement and put them back in what they normally would do rather than sitting around the emergency rooms and waiting, we would totally agree with that.
Yes, sir. Any members have questions for Mr. Jones?
Mr. Chairman, this is Delegate Ranson. I just have one quick question.
Yes, ma'am.
Mr. Jones, the sheriffs that did respond, would you consider them representative of the state, or were they sort of congregated into one area of the state?
It was all over, Delegate Ransom. It was, we had them from Northern Virginia and Southwest and everywhere. And I think Ms. Stanton may have put the answers in your notebook so you can look down and see what some of the specific answers are. But yeah, it was statewide. And it was, let me just say, 17 is not a big response. We normally get a much higher, but it's just been a lot going on here lately. And I know that we can follow back up, and we're getting ready to meet starting tomorrow, and we'll bring it back up, keep it on the agenda.
That could be great. We appreciate that, sir. Any other, Ms. Stanton, did you have something?
I'm sorry, Mr. Chair. Yes, I just wanted to note, I forgot to attach that data to your email with the materials members, so I will forward that out as soon as this meeting's over, and you can see the breakdown of who responded by locality.
Thank you very much. Delegate Hope.
Mr. Chairman, I just want to thank John Jones for his testimony. I kind of felt like the sheriff's position in the past was help give us some relief. And I appreciate him really focusing on the patient, because that's what this is really about, is the patient. I'm much more concerned about them. And so I appreciate that perspective. I think if we can solve that first problem, then the rest will come along. And so I appreciate Mr. Jones and his testimony today. Thank you.
Excellent. Thank you, sir. Thank you, Mr. Jones. Anyone else for John Jones this morning? Hey, John, thanks very much. And we would appreciate it if you continue to follow up and gather data. Any information you have on the 72-hour window as well would be great. And we'll keep working on this to try to alleviate some of the pressures on the folks that you represent.
Thank you.
Thank you, sir. All right. Next on the agenda, Ms. Wicker, who, on behalf of the hospitals, thanks for being here with us today, and thanks for your input already.
Of course. I'm going to share my screen. Okay. Are you all able to see that?
Yes, ma'am.
Okay, great. All right. So I've already introduced myself, Jennifer Wicker with VHHA. And for the purposes of this presentation, the homework that I had was to identify the ED boarding trends at community hospitals, as well as the workforce needs at community hospitals as we look to try to expand bed availability. So in order to do this, I conducted a survey of VHHA hospital members, and similar to what John Jones mentioned, the response on our survey was limited. I usually have a greater response. I'm hopeful that with a little bit more time, I'll be able to get more data for you. But I think I have enough to be able to give us an idea of what is happening in our EDs. One thing that I did learn as I conducted the behavioral health emergency department survey is that most hospitals collect this data cumulatively. So they collect all boarding data for all patients. The behavioral health only data is not readily available. It's something that we can get to, but it would take time and effort to be able to separate out that information from other patients. However, there were some hospitals that do separate out that information, and that's what I'll be reporting on for you all today. The survey time period covered the pre-pandemic, 6 months prior to the pandemic, and then the most recent 5 months that are available in terms of data. And the goal there was really to have an opportunity to take a look at what was happening, what we were seeing in terms of ED boarding before COVID, and then what we're seeing currently. In addition, I asked the members about the number of patients that they're seeing boarded in their emergency departments, and we did break that down by adult, children, and adolescents. Adults are 18 and over, children are 11 or younger, and adolescents are in between, so 12 to 17-year-olds. And we further broke that down by time increments, so 4 to 8 hours, 9 to 24, 25 to 72 hours, and then 72 or more hours. And one thing that I would like to have us remember as I'm going through the information is that all of the data will be reflective of all patients. So we do not separate out in the hospital setting voluntary versus involuntary patients. And then the last thing that I asked our members about were their staffing needs that would help them to open up beds that they're currently licensed for but are closed, as well as the costs. So quickly, the boarding trends that we were seeing is that most behavioral health patients that were in the ED, their wait times fell within the 4 to 8 hours or the 9 to 24 hour range. Children were boarded the least amount of time. Adults were boarded the most amount of time, and adolescents had the highest percentage of boarding that fell within the 25 to 72 hour range. Across all age groups, the greatest number of boarded patients fell within the 9 to 24 hour period. One particular hospital that I wanted to point out as an example of what some of our hospitals are seeing is actually a child and adolescent specific facility. And what they've seen with their ED boarding days is that they've increased by 2 days over the period between October 29 to June of 2021. And again, that is inclusive of voluntary and involuntary patients. But that just goes to show you that there is a significant increase in need overall of behavioral health. In addition, their overall ED visits have increased by 60% between March of 2020 and March of 2021. And this is looking at a primary mental health diagnosis. So I'm going to turn quickly to the workforce needs and costs. And this is actually just one health system's proposal or example. But within the health system, there are 4 hospitals, 2 of which would be adolescent focused and 2 that would be adult focused. And the way that I have this broken down is the number of beds that each hospital would be able to add with additional support for funding for temporary travel nurses or locum physicians. So for example, Hospital 1, which is adolescent focused, would be able to add 24 beds or open up, I should say, 24 beds. That would require 23 staff at a cost of $4.3 million. And then the rest of the hospitals broken down the same type of way for a total of 58 beds that would be able to be opened for the adolescent and 18 adults within this health system. at a total cost of $8.5 million. And that $8.5 million is over a 1-year period. They did explain to me that when they are doing contracts with travel nurses or locum doctors, temporary doctors, excuse me, they do start their contracts out at 6 months. So it would be half that cost. And then they add on in 3-month increments. And this just gives you an idea of the rates to hire the travel nurses, behavioral health techs, locum physicians. And you'll see that I also have indicated the cost of an employed physician. So 2 of the facilities have indicated that they would actually be able to hire full-time staff, and that would be the cost for the physician. But the other positions would be those temporary positions that I talked about, and those are the rates. And basically, if we're comparing these traveling nurses and locum physician rates, they are more than double what the normal cost would be to hire these staffing the staff. And that is all I have, and I'm happy to answer any questions that you may have.
All right. Thank you, ma'am. Any questions for Ms. Wicker?
Mr. Chairman, I thank you, Ms. Wicker. My first question to you is, or I'll make a comment first, and that is, I have I just ran the numbers here that you have on that slide about the hospital bed and your first example of 24 beds. $4.3 million. That's $179,000 per bed. I guess it's in the hospital 2, adding 16 beds at a cost of $2.2 million. That's $138,000 per bed per year. That seems to be a lot of money. I don't know how that compares to Medicaid or just trying to figure out, but how we figure out those numbers, but those seem quite high to me. But my question to you was, and this goes to Delegate Ransom's point, I think, is about the whether this is a regional issue. And so if the General Assembly were to take this up, trying to figure out where to place these beds, is this, I don't hear about this as much in Northern Virginia, I'll just say. And so I want to have a better understanding if in talking to your members about the boarding situation, if this is more acute in maybe rural parts of the state or in different parts of the state where we could maybe target some of these increases that are being proposed.
Sure. So I absolutely agree with the cost in terms of it being very expensive. And that's why a lot of hospitals have been working with a reduced bed capacity because of the costs associated with hiring these temporary nurses and physicians. As it relates to your second question, or your first question, the other one was a statement. It is all over the Commonwealth in terms of the boarding issue. I did not find it to be isolated to one particular area when I spoke with our members. However, as it relates to the opening of additional beds, not all facilities are able to do that. And so I think that we would be looking at we would be targeting certain facilities or certain health systems to be able to help with the bed issue. When I got the responses from the survey, some people provided information on the ED boarding, and then the questions around staffing, they didn't even answer it. So that goes to show me that that's something that they're not interested in doing at this point for whatever reason. But we do have a handful of hospitals that have beds available that are willing to open them.
Okay, good. Thank you.
You're welcome.
So that kind of leads us to another question. They didn't even answer the question about staffing because they're not interested. I understand. Well, this is not a highly profitable part of the world.
Let me restate that. Not that they're not interested. Some indicated that they are fully staffed already. And some are looking at other alternative options. Not all of the hospitals are looking to add beds, but maybe looking at outpatient services or other things to try to alleviate the pressure. So when I say not interested, I don't mean to say that they're not interested in helping.
Sorry, I didn't mean to hop on the semantics of what you said there. Are there any hospitals out there that have COPN requirements for mental health that we could review what they are from the past and how they're performing and how that works?
Adding or opening up these additional beds, are we talking about hospitals who have beds that aren't open, they're licensed for, they're not open? Are we talking about brand new beds?
I don't know. I'm saying in the past, did someone open a hospital somewhere under a COPN that they said in that they would provide 10% of their beds to psychiatric care, or that they would have a unit that dealt with, I don't know. I just wondered that it's ever been addressed throughout that process in the past.
I'm not sure I understand what you're asking in terms of what has been addressed, but COPN in terms of opening beds in the behavioral health space is not an issue. When hospitals want to add beds under COPN for behavioral health, they are usually approved. It's very rare that they're not.
Sure, but did anybody say I'll build 100 beds and I'll commit 25 under COPN? That's my question.
I'm not following your question. Could you restate it in a different way?
Okay.
I'm not understanding your question.
Well,
Mr.
so
Chairman.
I want to build. Yes, sir. Delegate, bail me out here, please.
There's no money in psychiatric beds, so we're not going to have a long line of businesses coming in here building these beds, and it's unfortunate. It's unfortunate. You shouldn't even have to go through the COPN process. Ms. Wicker stated that they usually are approved. They usually are approved, but sometimes they aren't. And, that's what's ridiculous. But what we need here is we need hospitals to step up and open up some more of their beds. I mean, and make sure they're for people that are TDO'd. And I want to make sure that, and I don't want to cut you off, Mr. Chairman. Of course, I never do that. One of the questions I did have for Ms. Wicker is in her cost estimates, are these sort of agnostic to whether or not these are TDOs or are these voluntary commitments in your price estimates? Because there's a difference.
They're behavioral health beds. As I indicated during our last work group, our hospitals are here to meet the needs of individuals who seek behavioral health services, whether they're voluntary or involuntary. And just because someone is voluntary does not mean that their presentation is any different or their needs are any different from someone who is voluntary. So, or involuntary.
Thank you.
So you're welcome.
One last one for me. I was surprised talking to the emergency room doctors over the last couple of weeks that they said the bulk of the people that are in the EDs are voluntary commitments. Did you get any information on that? And would you be able to go back and kind of confirm or check that for us?
I did not ask that question. I would say that, over the years, as we've been having conversations around voluntary and involuntary patients, our hospitals have definitely seen an increase in individuals seeking care voluntarily. So I don't disagree with that theory or that statement.
Sure. Might make sense as to why they're waiting, because the forensics are getting priority over the voluntary. Delegate Ranson, any questions for Ms. Wicker?
I think that you all answered them all or asked them all.
Awesome.
So I appreciate it. I appreciate Ms. Wicker reaching out and getting all the information for us.
Commissioner Land, do you have a comment?
I just was going to ask Jennifer if the cost estimates would allow them to take some of those populations that end up at the state hospital, which are the more assaultive, aggressive, medically complex, IDDD kids, that type of patient, or, I mean, from an environmental and staffing perspective?
So that was not, I did not ask that question. As you know, in order for our hospitals to take certain types of patients, hospitals would have to have the proper infrastructure and appropriate staffing to be able to do that. And we have been exploring those opportunities through the behavioral health pilots that we are working with you on. But for this specific survey, I was just focused on the ED boarding specifically, and as well as trying to figure out what the cost would be to open up beds that are currently unstaffed. And I would just add one last thing that I did want to mention to the work group as we're thinking about solutions. Obviously, inpatient beds is not the only solution. There are multiple opportunities that we have to either prevent someone from needing inpatient care or alternatives to inpatient care with, the partial hospitalization, intensive outpatient, those types of things. So I hope that as we continue these conversations, we're thinking comprehensively and not just focused on the inpatient option. But I did want to say that as I was preparing for the presentation today and speaking with members last minute on yesterday afternoon, I was advised by a couple of hospital members that just recently they've lost even more staff. And a lot of the staff that they are losing are their like behavioral health techs, because they are able to find work that is less stressful outside of the behavioral health space. And so I just want us to be cognizant of kind of the pressures that are on the hospitals and other behavioral health providers as we are trying to figure out solutions. And that is why we are looking at a situation in which it is costing so very much to get the temporary staff in the hospitals to be able to open up these beds. And with that, I will stop.
Yeah, Commissioner Land will probably add on to that in just a moment. Delegate Watts?
Yes, Ms. Wicker got into some of what I was trying to get a handle on. So let me try to combine three questions and see how. So to what degree are hospitals, as they look at their investment decisions regarding what we are looking at as being a temporary surge, as opposed to a systemic problem of long-standing that needs to be dealt with, so in making that investment? The second is to how much flexibility is there when a bed has been designated as a behavioral health bed to move it into general population or to move general population beds, given that a number of people were not doing discretionary medical procedures during COVID, to move available beds into mental health? Is there a system problem in the flexibility of moving beds back and forth? And then Ms. Wicker, excuse me, I'm sorry, Jennifer, just got into my other overriding concern is the availability of behavioral health staff issues, that how we can deal with them. So we're in that combination. Do you have a response? Give me perspective.
I will try my very best, Delegate Watts. So yes, to your initial short-term versus long-term need and sustainability over the long haul. The recommendations that I'm providing to you all today are a quick way to try to open up beds. And the quick way to try to open up beds, there is a high cost to that. The need for behavioral health is increasing overall, as we're coming out of this pandemic. So long term, we're still going to have that need. Even though we're talking about ED boarding as it relates to COVID-19 impacts, I think that unless we get all the other things in place, we're going to continue to see this back up in the ED.
And your hospital administrators reflect your perspective that you've just heard? Thank you.
Yes, ma'am. Yes, ma'am. And in terms of the flexibility to move general beds, as you like medical beds to behavioral health beds, there was some flexibility that was allowed during the pandemic. I'll be honest with you, I don't know where that flexibility still lays as we're coming out of COVID. But, and to go into your last question, the issue will still remain around staffing. So even if we were able to quickly, flex between medical beds to behavioral health beds and so on and so forth, we still need to find individuals to be able to staff those beds, because without the staff to be able to staff the beds, then patients would not be safe. In our hospitals, as we are seeing COVID cases drop, our hospitals are starting to see those general needs, those medical needs start to increase. So I think I hit on all of your questions. Happy to follow up if I missed anything.
No, I get, well, maybe this is moving to stepping back a moment, and perhaps this is Commissioner Land's response as well. We know that we will have a residual from the impact of COVID. This isn't going to be something that you can just lay hands on and all will be well. So there will be an ongoing increase in mental health services needs. But to what degree do you believe we're also looking at the fact that we are finally talking openly about behavioral health needs and people are seeking help as opposed to just an increased incident of behavioral health needs, which also the reason why I'm focused on that is the magnitude of the ongoing problem that we have. Is it finally publicly recognizing that this exists, which had been in the closet before?
I think that it's a little bit of both. I think that we've actually seen a true increase in the needs based on the pandemic and the isolation and all of the loss that people have experienced. And so that's going to be an ongoing increase. But also I think that we are hearing more talk about it. So it's becoming less stigmatized. And so people will start to get services because, to be honest, in the past, even if you had an issue, many people, like 75% of people, were not getting treated for it. Even if they realized that they had an issue, they were not willing to come forward and ask for help or to get the treatment that they needed. So I think it's a combination of both, which just
so our
amplifies
expansion demands are fed by several major streams. Then,
right.
Thank you.
All right. Well, Ms. Wicker, thank you. Before we let you go, you provided information, or maybe was a part of the CTAC expansion plan study that came out in October. You enthusiastic about that? Do you endorse some of those things? Did those recommendations make sense? And what would your thoughts be on that study?
So yes, had the opportunity to participate, and as I alluded to earlier, I think any opportunities that we have for alternatives, the hospitals will support. And we do have some of the CTACs that are actually within the hospital setting. So absolutely, our members are willing to partner in that space if there is an opportunity to do so. But think that it's a good option, and expanding the hours and the availability of the CTAC, I think, is very important.
Well, somewhere other than the emergency room, right? Norfolk General had 14 behavioral health patients in their emergency department on Monday morning. that were seeking care in other places. So, all right. If there's nothing else for Jennifer, thanks so much. We really appreciate and look forward to working with you throughout the course of this thing. So thank you, man. Commissioner Land. I think you're on mute. There you go.
I did have one quick question for Jennifer, if that's okay. If
Sure.
you could, would it be possible for your members that were willing to give the data around and the cost around opening those units to take a swing at doing what it would cost in addition to that, for them to take some of these populations that end up at the state hospital? Because I think that many of the beds that they're waiting for in the ED are state hospital beds, because we're so full. And so I don't know if that would be possible to reach back out and see if there is a rate that they would be willing, to take.
So the quick answer is absolutely. I pause only because I know that within the operations of some hospitals, they already have plans to make changes within their infrastructure to meet the needs of certain patients. Mm-hmm. And I would prefer to continue along that path and focusing on those members. And the member that responded, the proposal that I shared today is not part of that conversation. So I think that we just have opportunities to do that in two different ways, if that makes sense, Alvin. Okay.
Thanks. Okay.
All right. Commissioner Land, you're up.
Okay. Alex Harris is here with me today, and she's going to share her slides so that I can talk and she can worry about moving them. And just glad to be here again with y'all today and keep this discussion ongoing. And we are really committed to working together to find solutions, both for the individuals that we serve and our state employees, as well as law enforcement and all of our partners and stakeholders. So on the next slide, Alex, so the first slide, wanted to just say again, our hospital census is dangerously high. You can see on the chart here, 6 of our 8 adult hospitals currently are at or above 98%. The other 2, which are Southern Virginia Mental Health and Piedmont Geriatric, have recently been closed and have come off COVID outbreak closures. VDH has allowed us to reopen, and they are ramping back up. You can see that Southern Virginia is at 96%. And we've got Piedmont approaching 90%, and they're just continuing to take admissions from across the state into those units so that we have fewer and fewer delays. So soon we're going to be completely full again. And when that happens, like I've said in the past, it means there's no bed left at all. And so a patient may come in, but they're going to be on a floor, on a mattress, on a cot in the day room. It's not going to be safe. They can be victimized. There's nobody to provide the correct treatment for them. It also takes away from the treatment of everybody. So it's not a great situation. That's why we ask for them to be delayed. We don't decline, we delay. But so that's when those TDO patients end up, being delayed for transportation, sometimes for hours, if not days. That's a big part of the problem with us for our transportation delays, and we need to address it. And so I'm going to talk about in the next slide, some of the potential options for how we can do that better.
Ma'am, Ms. Commissioner, before we leave that, and I'm sorry to interrupt on slide 1, I apologize.
Oh, it's okay.
Because last week, on one given day last week, Eastern was 305 with 302 beds. So that really makes your point. How easy would it be to break down this by civil commitments, forensic commitments, and NGRI population? And I'd like to break down forensic further, but NGRI, we know, stay a long period of time. We understand that. So that's a bed that's going to be tied up for some time. But I'm really interested in breaking down forensic extensively, but just from start, forensic and civil. Would that be something pretty simple to make slide number 2?
Sure, we can do that. And we can send that out to the group so you can see it in advance of our next meeting as well. But typically what we're seeing is about 2/3, 66% of our patients are more of the short stay patients these days compared to in the past where we were almost typically 100% long-term chronic and forensic NGRI patients. So we can definitely get that information to the group.
Okay. Thank you, ma'am.
Okay. The other issue that we have that compounds our census issue is, of course, our staffing shortage. And that is really leaving our facilities feeling overwhelmed. So this kind of gives you a picture of where we're at, both for direct care on that top line, as well as our providers. So our psychiatrists, our nurse practitioners, our physician's assistants, all of those folks. So you can see that typically we are over 20% and up to 50%, 52%, as you can see there at Eastern State in our facilities across the Commonwealth. We had around 1,000 vacancies. So this is not just because of the pandemic. We were already running about 1,000 state facility vacancies in March. So when the pandemic hit, they've been, that's been increasing. We're now at just under 1,300, so almost an additional 300 vacancies. And we've been turning staff over. So we've been recruiting heavily and bringing them in, but we're not making any headway. We're losing ground. And so what the problem is that we're funded for 90% staffing. But with these vacancies, what that really means when you apply a 20% to the 90 is that we're really in the 60 to 70% range. But our facilities, as you saw on the previous slide, are at 100%, basically, and sometimes over 100%. So the safety for staff and patients is out the window. It's significant and serious. We're seeing increasing incidents and injuries. It's a real problem. So we have got to address it. One of the things that we found is that our direct care people, our nurses and our RNs, LPNs, are what we call DSAs, which would be akin to the behavioral health tech that Jennifer Wicker showed on her slide of what would be needed to staff units. That's what we call DSAs, direct service associates. All of those folks, we got DHRM last year, got the Mercer benchmark database for agencies to use, and we could purchase the data set. We had to do the healthcare data set because we're healthcare, as opposed to the other agencies, but we were able to purchase that and got it in April of this year. And when we looked, our staff, our direct care staff, healthcare staff, were being paid at the 10th percentile. So Jennifer's slide, when she showed it a few minutes ago, showed that they would be paying $32.50 an hour for those behavioral health techs. We start pay for our equivalent position at $11 an hour. So you get kind of a feel for why we can't keep or get people to come work for us. Plus, we don't have enough staff, so it's more work. It's a more aggressive, a more acute population that we're serving. So altogether, that kind of makes for an unsafe, and really people don't want to come and work with us. So the next slide.
And my apologies again for interrupting.
Sure.
So we're paying 12, but we are having to bring in contract workers because there's no way we can staff them with the full-time FTE we have. So what do we average pay those $12 an hour workers when we have to bring in contract workers? And can you provide that data for us? Where I'm trying to go is, I think that if we increase pay by as much as 40% for our frontline workers and maybe RNs and LPNs, we would be at an almost revenue neutral point as to where we are today, because we're having to pay such exorbitant cost to contract workers.
Yeah. So it's a twofold issue, because we can get some contract, and we do have some contract workers, and we can share that information and what that cost is, because it is higher, much higher, like 2 to 3 times higher, as Jennifer Wicker was saying. But also we do mandatory overtime. So you may come in for your 8-hour shift or a 12-hour shift and have to stay mandatorily for another shift. you may have in the past, in regular times or when we're fully staffed, work 1 weekend a month, and now you may be working 3 weekends a month, 4 weekends a month, just because we don't have the staff to take care of the patients, but we have to have the bodies, which means that people are overworked, they have no work-life balance, they're tired, they're, it gets unsafe. It can get really unsafe quickly. And that's another reason why people don't stay is the amount of workload. It's not, what they signed on to do. But that's the situation that we're in with our hospitals right now. So the workforce, the next slide, it's high risk, high stress jobs. They're low paying. And then as Jennifer Wicker also said, it's a scarce resource. There are shortages everywhere. It's not just for DBHDS. It's across the board in the behavioral health space. We have, a lack of all of the nursing type positions and providers. There's a shortage of providers as well. It's being in healthcare and having that direct face-to-face contact is also, as folks aren't as willing during the pandemic and as we're emerging from the pandemic to put themselves in that type of role. They can actually work somewhere else that is not, as much of a risk to their well-being and their personal health. They don't have to do that. So this is, we're seeing people that are moving towards, the $15 an hour for an entry-level position. And so people can go and work in other industries and not be in healthcare and in particularly mental health care, for, a lot more. They can be better in those industries and not have the same risk and stress. So those are some of the reasons that why it's occurring. And the next slide, these are the types of things. I think I may have shown this slide as our last one. We've been doing everything that the private facilities are doing and the private sector does to try to recruit and retain staff. But none of that's working because our base pay isn't where it needs to be. So, and we do all kinds of, the same types of things, the international nursing recruitment. We do locum tenens physicians and advanced practitioners, any kind of recruitment firms. We pay for recruitment firms to try to find folks, and we do all types of third-party contracting for telemedicine and that type of thing as well to try to get the care to the patients. So those are the types of things that we're doing. We're going to have to do more. And then finally, this is my real homework slide for you guys, was talking about some of the next steps for this. We are working with the administration. We have, like I said, we've worked with that Mercer data. We know what it's going to take to get us where we need to go. We've kind of messaged that up. We're waiting to see what we're able to share, what they're willing to support, but we are going to have to increase salaries. We're going to have to, and then once we get those approved for the new folks coming in, we're going to have to realign the current staff to those rates. We're going to probably have to do some small salary increases to those frontline direct care associate positions. And then our shift differentials, what we pay if you work night shift or weekend shifts, was also not at the benchmark with the Mercer data set. Our bonuses that we pay for sign-on or for retention were not at the rates that the private side is paying. So we'll have to work on all of those things. There are also inequities based on if you have a bachelor's degree versus a master's degree, and those types of things that will have to be addressed. And so we are going to work towards what that looks like and what we need to do to get our staffing where it needs to be, because that allows us not only to give better care, but we can be more efficient in our care and we can build throughput, which opens those beds. If we can't do the level of care that's needed at the intensity that's needed to stabilize the patient, because we don't have enough staff to do it, to do those interventions, then we can't move the patient out because they're not safe to go back into the community. And so this will not only help with our recruitment and the safety, but it'll also mean that we can actually move the patients through the system and get the beds open. So that will be a help. Next slide. Okay. So then we also have things that we have been working on to relieve the census pressure. And there are things like we've talked about at the last meeting, and we've talked about several times already today, is we really believe that an expansion of the alternative transportation provider contract to permit those sitter services so that law enforcement can be back out on the road and back to doing the public safety. So that would be for the folks that are on a TDO. That will be key, we think, and we're very supportive of it. We're going to continue investments in our dementia initiatives. So we have had really good success with the pilots that I mentioned, I think last time, with Mount Rogers CSB and Valley Health, which is one of the innovative long-term care facilities, the innovative company, and they have just purchased another 30 in Virginia. And so we are looking to expand to other sites within innovative. This model that we've put in place, they've been there since, we've been in place since March with a 45-bed unit, and we have not had any come back to the state facility since that time. And so it's really working well. They're being able to manage them in the community. And if we can get the dementia cases out of our facilities, which they shouldn't be there in the first place, then that's a positive. And so there won't be delays and needs for that population. And then potentially we could, if we don't have that need for that many dementia beds, geriatric beds, we could move some of those at some of our facilities like Eastern State and Southwest and all to adult. So that would be able to allow us to take more adult patients into those facilities. Then we have, we also had an RFP, so we're very close to, and we've closed the RFP, we're very close to having other long-term care facilities open that are specifically for both state psychiatric facility discharges as well as Department of Corrections discharges that need that level of care, including any NGRI patients that might need that level, any sexually violent predator populations that need that, all different types of patients that we have a lot of trouble discharging out of our facilities, and that way we can get those beds open and operating. We also are very hopeful of the investment in the crisis receiving centers as a part of the crisis continuum. And so that would be the no refusal drop-offs 24 hours a day. We do need to work on extending those hours, 23-hour crisis stabilization, and outpatient services being offered at those types of locations. So those are the, so we that's where we think that we need to go. So that, I think, is my last slide. We did have a reference slide on that's in your packet that would have the crisis system transformation. So if you needed more information on that, that's also there for you. So that was what I had for you today.
Well, thank you, ma'am. Your last bullet takes care of me asking everyone a question about the CTAC report. So thank you. And I really would be interested to see, I think we can help you if you can show us a snapshot across the system and maybe by facility of your full-time employees versus contract. Because at Eastern, for an example, 10 years ago, we paid full-time nursing compensation about $34 million. Today, we pay about $37 million. 10 years ago, we paid about $350,000 in contract workers. This year, that's over $8 million. Mm-hmm. So, I liken it to the teacher situation. We know we don't pay our teachers enough. But what we don't have as a comparable there is we're paying contract teachers 3X or contract companies 3X. So, I guess where I'm trying to go is it's at least I think the rough back of the envelope I've done at Eastern State, if we increase the compensation for not just hiring, but even everyone there, the direct service associates, the LPNs, RNs by 40%, it would cost us plus or minus $100,000, or it's essentially revenue neutral to where we are today. And I think if you can help us make that point to finance and appropriations, that it's not a 40% increase, it's taking what you're paying 300% for and bringing it back to the middle and allowing us to get closer to where we need to be on the scale, but at the same time, actually hire some people to work for us.
Yeah. We're putting all of that information together and sending it up.
Well,
yes, they have a process for us, and we're following the process, but we're making our point.
I understand, but let's make sure we get that to finance and appropriations after it bubbles up through the executive branch. Let's bubble it over, and especially things that don't make another appearance. Let's make sure we address those. Delegate Rance.
Mr. Chairman, Commissioner Land, I'm with you 100% on that. Slide 5 to me was very important because throughout the pandemic, a lot of the emails that we were getting and they were passed on to the sheriff's departments was about staffing, or a lot of times the hospitals were closed due to staffing. So I'd like to know a little more about where the recruitment is going, and has it started? When did it start? A little more specifics about what you're doing there. Are you reaching out to the community colleges? Are you reaching out to the four-year colleges? Are you reaching out to the technical centers, and targeting some of those students, even some of the high schools where they've identified students that are going into this career? Anything that we can do to help, or any feedback that we can get from you as far as outreach into, across the state into this field. I'd like to know a little more about that.
Mm-hmm. Well, we've been recruiting the whole time. We have people onboarding every 2 weeks in our, I guess it would be every week. Every facility doesn't necessarily have it on the same day. But it's ongoing, like every 2 weeks at every facility. We have a new group that's coming on that goes through orientation and gets, assigned to units once they're through their orientation period. We're just losing them faster than we can get them.
So, Mr. Chairman, Commissioner Land, is there an uptick in your staff, or are you still seeing shortages?
Oh, so my slide that I showed had one stat in it. We had 1,000 vacancies in just these direct care positions in March when the pandemic started. And then this past month, we had 1,289. So we're almost 300 worse than before the pandemic. But we had 1,000 before the pandemic. So, this is not a new issue. This is an ongoing issue. It's just gotten worse with the pandemic. People were scared to come to work. They can do other jobs that didn't have them face to face during a pandemic, and with this population, high risk population, as well. So I think it's just working against us that we are not paying appropriately. So it really works against us. We have a lot of things working against us that we're trying to address. So we didn't realize until April just how bad the salaries were. We didn't realize that we were at the 10th percentile because that wasn't a data set that was available until DHRM got the Mercer data set last year. And we were able to look at it, but not for our healthcare folks. We had to get a separate database, and we got that in April. So that's when we identified the real issue for us. And so that's what we're working towards, and have, briefed up through HHR to try to say, fire.
Delegate Hope.
Thank you, Mr. Chairman, for you and Commissioner Land, whoever wants to volunteer this answer. I'm interested in this next process of how we spend the American Recovery Act money, and whether or not any of these questions that we're touching on today, to Ms. Wicker's earlier points about private bed and also some of the salary issues, could be addressed during this special session. Can you point us into what's allowable? And Mr. Chairman, I think that we should, as a commission, prioritize, at least this work group, prioritize where those are, and seeing if we could send this to the full commission to recommend to the governor and to appropriations and finance.
Commissioner Land, do you know any ramifications about whether we can use the money or not towards salary?
I think that you can do it towards staffing, which we have an emergency, not just a pandemic emergency, but a just good old fashioned emergency from staffing perspective as well. It just happens to be during the pandemic as well. So we were asked, all of the agencies have been asked to send up what they would request or some ideas for requests for the ARPA. And we definitely put that on the list. And so we're hopeful that they'll find that is something that we could, request and be part of y'all's discussion during the special session.
Excellent. Delegate Hope, I agree. I hope that's something we can address, considering we're outlaying 3x times more money to other companies right now. I think it makes a lot of sense how this point and the next presentation will be some direct recommendations we can make to the full commission. Delegate Watts.
Thank you, Mr. Chairman. I was just going to underscore your point. At one point, I was just going to take my hand down because the commissioner addressed it when she said, we're doing what I call continuous recruitment way back when. Mm-hmm. And these are for her, but even way further back when, for me, when I was working with our prison system, we cut in those days, substantial amount from overtime simply by continual recruitment. But this is why I wanted to still underscore it to you, Mr. Chairman, as you bring this to the money committees. It's always easy to use still another excuse of why don't we do it this way? Why don't we do it that way? That Mercer data is just really at the heart of it. And while the COVID money is going to help us in the short term, we've really got to find somehow to look at the revenue needs that are very, very real here to support this program on an ongoing base budget.
Exactly right. Yes, ma'am. All right. If there's anything else, Commissioner Land, we've got a couple of other big presentations and a lot of folks that we want to hear from. So maybe if I'd stop asking questions every slide, we'd get through it a lot better. But Ms. Faison, if you would take the next presentation, and that is I know they're CSB review, but the Crisis Intervention Team Assessment Center expansion plan from this October seems to be directly on point with a lot of the questions that we have. So I'm interested in this. Thank you for being here, ma'am.
Sure. Again, Mr. Chairman, members of the work group, my name is Jennifer Faison. I'm here on behalf of the Virginia Association of Community Services Boards. And as I explained before we went live, my homework assignment, because I kept running my mouth about the CTAC report that DBHDS put together, and wouldn't it be beneficial if we took a look at that and those recommendations, and just to touch base with the group on what this looks like from the CSB perspective. And if I might, just for a minute, provide a little bit of context about CIT in general. This is one of the great benefits of CIT is that it really does drill down into communities and focus on building those partnerships so that the CIT program can work and be effective. And the CIT assessment sites, the CTACs, are actually the culmination of all of that good work. So you don't just wheel in hot into a community and throw together a CTAC and expect it to work. There's a very vigorous process that the entire community engages in. So I want to just make sure that is clear to everybody. So you can't just pop these up without some thought in putting them together. And that's why they are as successful as they are. The other bit of good news with CTACs is that the CSBs and DBHDS work very closely together and collect a lot of really good data on utilization and those kinds of things. And I'll touch on that a little bit more as I walk through some of the recommendations in the report. It's a pretty straightforward report. There are three, Mr. Chair, as you mentioned at the top of this meeting, the basic findings are why we are all here. So the work of this group in putting the report together really those findings are not new, and it is literally how we got into this work group. And so there are 3 recommendations in the report. The first of them is to expand the availability of the existing CTAC sites and make them all 24/7. And so I think that of course would be one way of assuring that law enforcement had access to the ability to drop someone off and transfer custody, so that evaluation, pre-screening evaluation could occur at the CTAC without the officer needing to remain there. So that, expanding them all to 24/7 seems like a common sensey approach. I will say, again, back to the data collection piece of it, it may not make sense in some of these areas to have full 24/7 all the time if your data doesn't show that is an efficient use of those resources. So, for example, we know when the calls are coming in, we know when high volume is. So you maybe wouldn't want your CTAC open on Wednesdays from 5 p.m. to 2 a.m. if nobody's coming in on Wednesday during that time period, or utilization is generally very low. So I think just a blanket expansion of all of them to 24/7 probably isn't quite right. But we do have good data to help us drive those decisions. And I will say that my sense of it is that even if it wasn't full 24/7 expansion, that every CTAC location would appreciate expanding in some way. So in order to meet their data-driven volume, that maybe they only are able to have it open 5 days a week with adjusted hours on the weekend, and they would like to do better than that, but maybe not quite 24/7 because their data doesn't support it. So I think it would be important to look at that on a case-by-case basis, but would say that in general, folks are interested in expanding CIT hours of operation and days of operation. So I think that recommendation would hold, and we would absolutely support additional funding to make that happen. The second recommendation has to do with, well, actually, they're not even listed as recommendations. They're listed as options, right? So creating crisis receiving centers with the ability for medical and psychiatric intervention. And so the commissioner touched on the crisis receiving centers briefly. This would be not only an expansion of a CTAC, but really an expansion in the role of the CTAC, and it would place it in a different place in the crisis continuum if they were to be co-located or turned into, if you will, a crisis receiving center. And so we have some CSBs in some areas that would be interested in having a crisis receiving center. It's a model that does make sense. I will say, as it is laid out in the report, that option would, based on the way that the funding formula is laid out, would require shifting funds and perhaps closing some existing CTACs in order to support the funds necessary to have full crisis receiving centers, one per region. And so we would not be supportive of dismantling any capacity for CTACs in communities in which they already exist. And I know that John Jones is not on here, and I won't speak for him, but I would imagine that his members would feel similarly about that. It is a highly regarded service that's utilized often. So supportive of the crisis receiving centers, but would not be supportive of taking resources away from communities that have developed CTAC programs in order to support that. And then the third option was really a hybrid of those two, where you would have, you would keep your existing CTAC locations, and you would, when, for example, a CTAC was not open 24 hours a day, then that law enforcement officer would have an opportunity to take somebody to a regional crisis receiving center during those off hours when the CTAC proper was not open. Again, we would not be opposed to stepping into that space. A couple of observations. One is that in the course of history, back in my day, as they say, the position that we have found ourselves in is part and parcel of why we are doing STEP Virginia in the way that we're doing it. And so the General Assembly has decided, and the community and DPHDS and our stakeholder partners are supportive of trying to create a baseline level of supports and services across the state so that where you live doesn't matter. And if we cannot find a way to make sure that these crisis receiving centers are situated and truly available within a particular region to both law enforcement and CSBs in order to serve people in them, we'll end up in the same spot, right? So we'll have this great service that exists in these locations that realistically, let's say in a region as big as Region 3, a law enforcement officer is not going to drive is not going to drive another 3 hours to the receiving center. So I think, again, the report is very well done. I'm sure the author, Stephen, would be able to brief you on all of the nuances, but they do exist, and they're not necessarily, the report would be 500 pages long if we talked about everything that we need to talk about. And so for that reason, I just would say that none of the three options that are presented are perfect. But I think that we can have some conversations about how to really utilize funds and resources to expand the existing CIT sites, perhaps the number of sites, if that makes sense, but focusing on the days of the week and the hours of the day that those sites are available to law enforcement. And then one other thing that I will add, and this is part of a conversation that when this work group was working and developing these options wasn't really part of the conversation. And that is with Project Bravo, there is going to come online some, as you all are aware, some payment source through Medicaid for some services that are currently not Medicaid reimbursable right now. And one of those is a 23-hour observation. And that really, to me, is kind of a sweet spot and a step towards a crisis receiving center. So if you wanted to do, an interim step, you could realistically think about having a CTAC location that also had the ability to do 23-hour observation, and you put those two together, and then you've got a plan for diversion, right? Because not only in that instance do you have an opportunity for somebody who might be meeting criteria to be served in a less restrictive environment, if that is available, but you also have, you have the ability to get that evaluation, all the things that the CTAC regularly does. And so the CSBs have been looking very closely at how they might attach a 23-hour observation capacity to something. As Jennifer Wicker mentioned, some of the CTAC locations are actually within a hospital. And so would it be possible to expand within that to do some 23-hour observation? Would it be possible for those freestanding CTACs to gain space and do it that way? Is it possible to tack it on to a crisis stabilization unit? All of these things are worth exploring. And I think from the CSB's perspective, it's a really exciting opportunity to put something in the mix that it's really not rocket science, right? It's a pretty basic thing that will fill a great need and provides a real opportunity to keep people out of the state hospitals. And so that, again, the reason I bring that up is because it was not kind of part of the landscape when we were having those initial conversations.
Well, and I think that's a great, so I ask you this, knowing that that one of my CSBs, Colonial Behavioral Health, in combination with Riverside CTAC, which is in a hospital, has a $300,000 request to DBHDS to do just that, to have a 23-hour, kind of taking some of the elements of the report. Do you know how many CSBs have already, and maybe you and Commissioner Land, do you know how many CSBs have already applied for expansion services like this? Where we are with that, because back to Delegate Hope's earlier question, if we've got 5 requests of $300,000 out there to expand like this, if we can put those together and take that to the money committees, this is existing service ready to expand based on a report that we've done. So how much information do you have on where we stand there?
If I can just really quickly, the 23-hour component is not actually included in the report. It's not part of the report. The Crisis Receiving Center, I think it's mentioned in there, but it's not like as front and center, I think, as the conversation has evolved. So it's in there, but it's not in there kind of in this way. And I will say, and Commissioner, you correct everything I'm about to say, but what I know is that there were some funds that were available that CSBs could apply to that were CTAC specific. And I know of 2 that would be looking at this 23-hour capacity. But outside of that, in preparation for that service coming online in December, and it will not be reimbursable till December, which is, probably fine. You got to figure out how you're going to do it. And that's going to take a little bit of time. But in preparation for that, are making plans outside of anything they might have been applying for with DBHDS.
I'll add, if I could just add, I think that we're looking internally to start with regional CTACs that would have these additional services that I mentioned on my last slide, which would be the 23-hour observation, the outpatient services, all of those types of services combined. And that's kind of, I know Heidi Dix was planning to hopefully be here, but she ended up not being able to be. But she's the one that's kind of leading that for us, and she can give a lot more information. Maybe we can have her come at the next meeting. Give an update on that. But that's also something that we've kind of sent up as part of this idea of what can we do with these ARPA funds to go ahead and make sure that we're advancing STEP Virginia and we're advancing the crisis transformation, because that's really the future for how do we get the prevention and wellness and keep people in the community instead of ending up at the state hospital. How do we go ahead and do that instead of waiting until another biennium to move forward with those last 3 steps? Is there a way that we could use these funds, because it's through 2025, some of the use of it, so we could at least do planning and start implementation, because it takes a while, because of course we also have a staffing shortage. So how do you staff it even if you build it? But to kind of get us ramping up to doing those things.
And this looks like a great example, a great place to use ARPA money and kind of the hybrid model. Of course, it's most expensive, but we could establish some new regional centers in places that don't have them, but build on the CTACs that we do have in place. And that sounds like what this money was designed for. I'm sorry, Ms. Faison.
That's okay. I was going to say, we would support expanding the hours and days of operation in our existing CTAC sites, because I wouldn't want to lose sight of that part of it in talking about some of the other things that we might do, because we already know they're effective. We know they're doing good work. decision making on how to expand what we have already existing and make sure we put that front and center. And I'm happy to hear, Commissioner Land, that you're going to or that you already have put up proposals that would be similar to what we would expect to advance as an association as we work with members of the General Assembly. I'm sure there are other intersections, but I would say too that the department's vision for the Crisis Receiving Center, which would be more comprehensive, might differ slightly from what the CSBs would envision it as a first step. And I can also say that we're looking at CSBs at this ARPA money in a very focused way. And we understand the kind of one-time and short-term nature of it. And that, of course, leads itself to some things more than others. So, for example, if you needed physical plant to operate a CTAC with 23-hour capacity, then we would certainly want to take advantage of ARPA funds to do that kind of building, buying, those kinds of things that would be appropriate for short-term and one-term money. So we are trying to keep that in mind and keep focused on what can we do in that period of time, and then prove to you that it works and look at maintenance of effort at the time of the
Okay. Super. All right. So it looks like this report, and that's a great foundation for us going forward. Anybody got a quick question for her? But I think we're going to be Delegate Watts.
Just a quick question to underscore, time is of the essence. The critical work is being done right now for whatever we decide at the end of the summer on the rescue funds. And 2025 is here before we know it, based on my experience in trying to get the center established in Fairfax County and what a long time frame that involved, including much of it being significant issues about the money available for capital to have the kind of space needed for the calm 23-hour observation that we're talking about in separate space, etc. So hard numbers, I hope, are right now in the hands of those that are making proposals for what we initiate by our action at the end of the summer.
That's right. Excellent. Time is now. Yes, ma'am. All right. So we're going to delve into that a lot deeper, I think. And so if we could go to Ms. Wright and Ms. Wilkinson, I appreciate y'all sticking with us. Really my bad for asking for all of this information in a 2-hour window, but that's typical of me. So my apologies, but we are looking forward to hearing from you. And then we'll go to public comment very quickly after you're done. So Ms. Wright.
Thank you so much, Senator Mason. We're happy to be here. I have my colleague, Kelsey Wilkinson, on the line too. We're just going to do a quick run through on VMAP, what it is and why it's important, especially given all of the conversation that we have had today in the subcommittee. I'm the program director for the Virginia Mental Health Access Program. My name is Allie Singer-Wright. Thank you all for having me. I'm going to run through just a couple reasons as to why this program came to be in the first place. We know nationally that 1 in 5 children have mental, emotional, or developmental behavioral problems. 44% of these kids have onset by age 11. And the World Health Organization reports that half of all mental illnesses through adulthood begin by age 14. Knowing those things, the important piece and how our program evolved, a lot of these patients, pediatric and adult, but we focus on youth, children, and adolescents, see their PCPs before they've ever been diagnosed with a mental health condition. Try to get my screen to work here. There we go. 1 second. Can you all see that still? Good, great. There's a really great report that comes out every year or so. It's called the State of Mental Health in America. It gives us some state statistics that are really helpful. And the most recent one showed us that 14% of Virginia children have had at least one major depressive episode. 53% of these kids who have had a major depressive episode did not receive treatment in our state. And then of those with severe depression who did end up receiving treatment. Only 26% received consistent treatment. We also know that suicide is the second leading cause of death nationally for children ages 10 to young adults ages 24. That is a significant number. And here in Virginia, a study about 2 years ago showed that 1 in 4 females and 1 in 8 males youth had seriously contemplated suicide in the past 12 months. Also locally to our state, 1 in 3 Virginia high schoolers surveyed felt sad or helpless for over equal or over to 2 weeks in a row. And in the past year, this was a survey done in 2020 by the Department of Health, 12% of Virginia high schoolers and 14% of middle schoolers actually had made a plan on how they would attempt suicide. Knowing all of that and looking at our state, all right, we have a lot of kids in need. We also have a major behavioral health professional shortage, workforce shortage. We probably all know here that's a federal designation from HRSA. 64% of our localities do not have enough mental health providers to treat their population. We also only have 13 child and adolescent psychiatrists per 100,000 kids, not a lot. And knowing those two things, at the same time, we have pediatricians who nationally surveyed 65% reported they lacked the mental and behavioral health knowledge and skills to treat their patients or to even screen and manage them. So I don't know, a lot of people may or may not know pediatricians are taught to refer in school. They're not taught to treat, manage, or screen for mental health. They're taught to refer. However, these first two statistics show that we don't have a lot of places to refer to. Adding a pandemic on top of that, of course, we're going to see a lot more and possibly different mental health outcomes. We saw a survey nationally last year, the first couple months of the pandemic, that also by Mental Health America. They were surveying kids who were experiencing different symptoms and different diagnoses such as anxiety and depression and what was contributing at the time to those conditions. And loneliness and isolation were the primary contributors to their anxiety and depression during the pandemic. We then, in the first couple months of the pandemic, wanted to see what was happening in our state. So we surveyed our pediatricians in partnership with Commissioner Land at the Department of Behavioral Health and our Virginia chapter of the Virginia or the National Association of Pediatricians, the VAAP. We wanted to see pediatricians were seeing different needs in their offices. 88% of pediatricians, again, this is in July of last year, said that they were seeing an increase in children coming in with mental and behavioral health issues since COVID had started. And 62% reported they were not able to currently meet that need. You can see here the most common to new, these are new needs since COVID started. Again, anxiety, depression, other behavioral issues not currently reported previously. So a lot, we know we had a need, and again, being exacerbated, as we've mentioned a couple of times already on this meeting, because of the pandemic. If you want to compare us to nationals and other states, we are the 41st lowest for our number of behavioral health providers. That includes therapists, social workers, psychiatrists, but we are 41 in the country on how many providers we have to meet our population's need. Only 2 counties in our state, this map shows our state map, how many child and adolescent psychiatrists are available. There's only 2 counties, 4 localities total that have enough child and adolescent psychiatrists to serve their kids. The yellow have a high shortage, red has a severe shortage. The gray counties don't have any child and adolescent psychiatrists. When we were evolving into this program and developing it many years ago, rewinding before COVID, we're in 2018, about 2017, we wanted to see, does Virginia need a mental health access program? I'll explain what that means. But we first started with pediatricians and we asked them a couple questions. Do you have adequate access to child psychiatry for your patients, given those statistics I just talked about? Do you have adequate access for other mental health services? Are you able to meet the need of your patients coming in, again, before COVID? And when you need a consultation possibly with a psychiatrist or other behavioral health provider, do you have access to that? Pediatricians have access to other types of consultations with cardiologists, endocrinologists. Do you have that same type of access for a child psychiatrist if you have a kid in your office needing support? Across the board, as you can see here, strongly disagree with all of these. The answer was no. That's where we came from and why we were born. Again, the Virginia Mental Health Access Program, it's not a new concept. These programs exist all over the country, and we are, fortunately, because of our state legislature, one of the better funded ones. But this is a concept that came out of HRSA many years ago. And how it works is, first, let's start by training and teaching our pediatricians, our family medicine physicians who treat kids, our PAs, our NPs. Let's train them to manage mental health in their office to their comfort level. Again, they're not trained on this in school. And see if we can get them managing some mild to moderates to their comfort level. And then another piece of the program, we have a consultation line right now statewide, a consultation line that gives these primary care providers treating children and adolescents access to those very rare child and adolescent psychiatrists. They can call right now 40 hours a week. Within 30 minutes, they're going to get a call right back from a child and adolescent psychiatrist to help them with their patients. So this combination of education and a consultation line is this mental health access program for pediatricians that has been duplicated or replicated all over the country. And so we have a very robust education component. I'll briefly run through that in just a sec. We have our consultation piece where we have these child and adolescent psychiatrists on call. We're also developing regional hubs right now that have child and adolescent psychiatrists who are actually regionally based, so they're familiar with their providers, they're familiar with the resources available. We're adding other behavioral health providers available for consult. Not everything needs to go to a psychiatrist. There's other providers who can support. We're also adding care navigation in our regions right now. This is to help PCPs find additional referrals and resources. We want them to manage as much as they can, but we know a lot of kids are still going to need additional support. And so we're asking them to do more screening, diagnosing, managing. We've taught them to do some of these things. We have this consultation line to help. We want to take a little bit back off of them. We'll help. We actually have care navigators work with the patients and the families to get them to the right resources when they're needing more care beyond that primary care practice. So oftentimes we have kids maybe who've been discharged from an inpatient facility or an emergency room. They're always told to go to their primary care provider, who might not know even what some of these medications they're on are. They need to find an appointment in a couple months. They also need to be managed in the meantime. These are all times that VMAP can come and support these primary care providers, or just children, presenting with basic anxiety, possibly suicidality. We also have a fourth component. We want to be able to do some of our consults via telehealth, where our consulting psychiatrists actually can see the patient and their family to help with the consultation and better get them to the care and services they're needed. We're working on implementing that right now. We have our education piece and our consult line is available statewide. At the same time, we're adding some of those additional components, our care navigation, additional behavioral health providers to help on the consult line, and regional services. In each of these regions, we have a great partnership in the north and the east. Children's National and Inova in our northern region. In the eastern region, we've partnered with the Children's Hospital of the King's Daughters. We have full regional hubs there, full VMAP staff, a regional child and adolescent psychiatrists, regional LCSWs, and care navigators helping their PCPs in their region. The central region and the southwest region, we're currently onboarding and training those staff right now. The southwest, we've actually partnered with the CSB, which is unique. As you can see, typically we partner with a lot of hospitals. Mount Rogers has been great to work with. We're also working with VCU, hiring VMAP staff at their facility. And then in our western region, we are hiring right now and starting our onboarding and training shortly. So how does this all work? Again, we have that mental health education piece. We hope we can train as many PCPs in the state to better manage, screen, diagnose, and treat mental health. We also have our consult line. They don't have to do the training or education to call our consult line. Any primary care provider treating a child 21 and under can call. But we do hope they're very complimentary, and you don't want to teach a provider to screen and then not support them through what might come out of that screening. So we have this consult line. We do a brief intake. We send them to their regional hub, and that's where they can receive a consult from either a child psychiatrist or other behavioral health provider. They can receive care navigation services. And then when we fully implement our telehealth component, that might be needed as well to help with the consult. So far, we have statewide 521 providers registered. These are, again, PCPs treating children and adolescents. We've provided almost 1,100 consults. This was through the end of May. and 451 providers statewide have trained in one of our educational programs. We have 3 different very comprehensive education programs. I won't go into depth on all of them. I will point out, because we are state funded, these are all at no cost to primary care providers. The first one is a national program that we've actually contracted to teach to our state PCPs. If you look that up nationally, it costs about $2,300. There's like a 2.5-year waiting list at this point. Because of our state legislator and our funding, we're able to do that every couple months for our state PCPs. No wait list. We'll get them in a couple months to this program, and it is a really big game changer for our primary care providers. We also have Project ECHO cohorts and QI initiatives. Again, won't go into depth, all teaching PCPs to manage mental health for their pediatric patients. I will point out our QI project is pretty impressive. We do really want every PCP to be screening as much as possible. This was our most recent cohort. We were teaching them to screen for mental health and depression. And you can see the before and after as they finished the project, how many of their patients were getting screened by the end of the project. We help them integrate into their EMRs, how do they bill for it, and really walk them through integrating this into their practice workflow. Funding, how is all of this paid for? We have started with a bit of HRSA funds that came through the Virginia Department of Health. That's what funds all of these programs all over the country. Then with successful advocacy and support from our state legislator, we got additional funds that come out of Commissioner Land's agency, the Department of Behavioral Health. They in turn named the Medical Society of Virginia Foundation, the program administrators, and that's who I work for to run the program. Half of our funds were frozen in the last fiscal year. We'll receive our full funding very shortly in a couple weeks. And we also get funding from other support as well. Some counties, some foundations support us. And we're also looking, and we receive some in-kind support from some of the hospitals that we work with. Executive committee is built of our partners at the Department of Behavioral Health, VDH, here at the Medical Society. Our call centers run out of VCU. This is our executive team. We're also, you may have heard of the new Unite Virginia network that has come to the state that was paid for by some CARE Act funds. VMAP's also partnering with Unite Virginia to get as many pediatric behavioral health providers into that network as possible. We want our care navigators to use it for resource and referral support. And we also want everyone to be able to use it and have as many pediatric behavioral health providers in that network as possible.
And if maybe we could head to next steps so you can tell us what you're going to need from us, because this is great information.
Yes, we are there. I just wanted to thank all of our partners from all over the state. That is the end. So that was great timing. I don't have any asks at this time. I do want to pass it to Kelsey. She has a couple things she wanted to add. So thank you all for having us today.
Great. Thank you. Sorry for the rush. That's great information.
No.
Not a problem. I'll keep it very short. Kelsey Wilkinson, also from the MSV Government Affairs team. It's great to see you guys, and thank you so much, Senator Mason. As far as asks go to the members of this subcommittee, we don't have anything specific right now. You'll be hearing from myself and Clark Barano from our Government Affairs team at the MSV. We'll definitely be reaching back out to the members of the subcommittee as the special session approaches with some more information regarding expansion of the VMAP program. Those conversations are kind of ongoing right now as to what the expansion will look like and what additional funding it could require. In the meantime, our team is continuing to advocate for the full amount of $5.4 million of general funds to ensure it is reflected in the budget this year. It was unallocated due to COVID-19 and then reallocated and restored during the last special session. So you'll hear a bit more from us in the coming months. So thank you so much for your time today.
Oh, excellent. And everywhere we start, we see how much work we need with adolescents and with children. So really important program. And thank you for taking us through it. I'm sure we'll have more to delve into beyond. So thanks very much. MJ, so I got us a little behind. Could we go to our public comment and let folks in? And I'll ask people that come in. We've a lot of information today. Please help us by pointing to the target of your specific comments and letting us know what you're thinking. But we definitely want to hear from everybody.
You are muted, sir.
I just let Anna Mendez into the room. There's also a Patrick Halpern that wishes to speak. And anybody else in the room that wishes to speak, please raise your hand electronically and I will get you into the room. But for now, we have Anna Mendez, followed by Patrick Halpern.
Barely got you in the morning, but good morning, Ms. Mendez.
Good morning, Senator Mason. I want to, a lot of information was covered today. I'm Anna Mendez. I'm the Executive Director of Partner for Mental Health in Charlottesville. I want to start by saying that if there are delays between the end of an ECO and the beginning of a TDO, which we suspect is happening at some places in Virginia, this is contrary to Virginia code and is kind of legally dubious at best. We believe that the TDO clock must start the minute that an ECO expires, even if the person is not yet in their facility of temporary detention. Our organization is not philosophically opposed to involuntary treatment in all cases. We actually believe that it is at times a regrettably necessary component of our mental health service system. But we also believe that it must be executed in accordance with state code, or else our entire, doing it otherwise actually puts our entire system of involuntary treatment at risk, which is an unacceptable threat to public safety and, most importantly, safety of a person in a mental health crisis. I would like to remind the committee that Virginia has the third highest rate of inpatient hospital beds on a per capita basis. I also want to make sure that you are aware that, at least in Charlottesville, the majority of people who enter a crisis are people who are already known to our mental health service system. This means that opportunities for interventions are generally being missed, and that these ECOs and TDOs are generally preventable. We are really excited about Project Bravo and the intensive outpatient and partial hospitalization programs that are going to be brought on board as that work. And these programs could really help in terms of preventing the need for ECO and TDO. However, they have to be reimbursed at a Medicaid rate that is sufficient to make the service successful. And we actually believe that the proposed rates will not achieve that. So I wanted to plant that seed in the minds of the committee. I also would like to remind the committee that we believe that right now approximately 25% of all individuals on our state's extraordinary barriers to discharge list are stuck on that list due to the NGRI process itself. These are individuals who are clinically ready for discharge as assessed by their expert clinicians, and that the only reason they are still in a state hospital bed is because of the judicial process has not caught up with their service providers. So this is absolutely something that needs to be remedied. I also would like to point out that state hospital beds are increasingly being utilized to address our competency crisis. 25 to 30% of misdemeanor charges are people are being stuck in these state hospital beds waiting for a competency process that ends up taking longer than if they were just convicted of their charge. We're not suggesting they should just be convicted, but I would like to put that in a frame of reference for you. I would also challenge the committee for every American Recovery Act dollar spent increasing inpatient care, that we spend an equal number of those Recovery Act dollars strengthening our community-based system of care, because we can keep increasing access to hospital beds all we want, and we will just continue to have this problem if that is all we do. Thank you all so much for your service to the Commonwealth.
Thank you, ma'am. You hit on a lot of the hot topics that we're extremely focused on, so thank you. Next speaker, sir.
Mr. Chairman, we have Patrick Halpern, followed by Bruce Cruiser, and then there is a Jonathan Green, who I will also bring in the room.
All right, Mr. Halpern.
Sir, thank you. Chairman Mason and work group members, I appreciate you giving me the opportunity to address you this afternoon. I am Patrick Halpern, and I serve as the president of the Virginia Crisis Intervention Team Coalition. And wanted to comment on a couple of things that were brought up today related to workforce issues, CIT assessment centers, and the development of crisis receiving centers, or what we refer to as CRCs. First, as it relates to workforce development issues, I want to bring up the obvious issue that the Commonwealth faces, in that while both our private and public hospitals are currently hamstrung by their own workforce retention issues, our whole crisis system transformation is predicated on expanding our workforce significantly, whether that is Step Virginia, Project Bravo, Marcus Alert. All of these initiatives require significant workforce expansion efforts for behavioral health providers. So I hope that this work group and the commission supporting it and the General Assembly will consider, what incentives we can provide to help us bolster the workforce necessary to create a more modern crisis response system. Secondly, as it relates to CTAC expansion and the development of crisis receiving centers, this is really predicated on the model that Virginia is moving towards, the Crisis Now model. And without these full service CRCs in place, we will not realize the benefits of the Crisis Now model in Virginia. My community down here in the New River Valley has just opened July 1st, we'll be opening a CRC with Department of Behavioral Health funding. And we were very excited to prove the efficacy of this resource around the Commonwealth, and are grateful for the support of the department. But really, being able to keep people out of emergency departments is really the direction we should be going. Behavioral health assessment should be decoupled from medical systems of care. As we know, emergency departments are very chaotic environments and are not the best place for someone that is in crisis to be located. So I'd really encourage this work group and the commission as well to fully explore how we could support CRCs across the Commonwealth to fully realize the Crisis Now model and assist communities and fully help citizens in the Commonwealth. One last comment I would like to make, and it was really sparked by Ms. Mendez' comment prior to me. Law enforcement in Virginia is really in kind of a confusing place as it relates to executive orders and the code, and it is complicated by a recent Attorney General Attorney General Herring back in the late fall of 2019 issued a opinion that relates to the service of temporary detention orders. And in his opinion, he told Commonwealth law enforcement that a TDO is an action order. And so when law enforcement executes a temporary detention order, for the law enforcement officer, it is directing them to transport an individual to a receiving hospital. Law enforcement across the Commonwealth are completely confused right now. We have an executive order from the governor that is telling them they have to execute that order and then sit in an emergency department until a bed is available, whereas their chief law enforcement officer, the Attorney General of the Commonwealth, is telling them, do not execute a judicial order if you have nowhere to go. And some law enforcement officials have reached out to the Attorney General to seek clarity, because right now they're being told two separate things. And fundamentally, it is, as we all agree, it is the individual that is supposed to be in custody that is suffering. But we really need clarity for law enforcement in these situations as well. And I do agree that we need a short-term solution to find beds and make them available. But I would also agree with Ms. Mendez that, the future direction of care in the Commonwealth is community-based, and we need just some temporary funding until our system transformation is complete and we can hopefully keep people in the community and continue to serve the Commonwealth to the best of our ability. I appreciate your time and I appreciate your service, and thank you for letting me comment.
Excellent points. Thank you, sir.
Mr. Chairman, we have Bruce Cruiser followed by Jonathan Green.
Mr. Cruiser, nice to see you again, sir.
Yes, sir. Mr. Chairman, members, thank you. I'm Bruce Cruiser, Executive Director of Mental Health America, Virginia. I was also a member of the Crisis Intervention Team Assessment Center, or CTAC Center work group, and just want to commend the comments that have been made previously supporting that approach, because as you said, Senator Mason, that we have that in place, and the report has indicated some options how we could utilize those resources. And as Ms. Faison said, there are several options, but they all kind of come to the same place, which is community observation and treatment for someone, and diverting them from the need to even go to the hospital or jail in the first place. So I really think that's the way to go. And we a lot of work went into those studies, to that report. If we had no behavioral health system whatsoever and we needed to create one, we would spend a lot more time looking at these community options and how to develop a continuum of care in the community short of hospitalization, because that's the most cost-efficient and most patient-centered approach with the best outcomes. So sometimes I think it helps to stop and say, okay, what kind of a system should we have, rather than how do we backfill it? But we're in the reality of needing to backfill it. So I support those efforts, and thank you all for what you're doing.
Thank you very much, sir. We do know where we'd like to go, but my mental hospital has 1773 on it. So we've got a long-standing system. Our next speaker, sir.
Jonathan Green.
Mr. Green.
Thank you. I apologize for my apparent lack of video, but I trust everyone can hear me all right.
Sir.
I'm Jonathan Green with the Department of Magistrate Services, Office of the Executive Secretary. And I'd just like to make a couple of comments based on the discussion that was had during John Jones' presentation and regarding the 72-hour period. One clarification that I think is important from our perspective is that magistrates are only involved up until the point where the TDO is issued. After the temporary detention order is issued, any subsequent hearings are done by either a judge or a special justice. The person will not come back before the magistrate for anything to do with the involuntary commitment hearing that is supposed to happen within that 72-hour period. Because that happens outside of my department, obviously I don't have any statistics or insight that I can give on what happens to those individuals. I think Mr. Jones' comments about the mixed response are accurate, but I would add it's important to note that per the code, there are a number of additional steps that have to happen between the time the TDO issues and the time that the involuntary commitment hearing can proceed, including additional evaluations, involvement of counsel if necessary, and so forth. And I can well imagine that that may be complicated in situations where the person is being temporarily boarded in an emergency department somewhere versus being in a mental hospital where that is set up to handle those types of activities on a routine basis. And that's all I have to add.
That makes sense. Thank you, sir. And I think sometimes I cloud the issue by interchangeably using positions. So thank you for clearing that up for us. Is that our last speaker, sir?
Mr. Chairman, that does complete the list of attendees who wish to speak.
Excellent. If any speakers feel like I rushed them through, please send us further comments to our email on the commission or to mine directly, which is district01@senate.virginia.gov. So my apologies for for the short timeline for that and for Ms. Wright and Ms. Wilkinson's excellent presentation. Happy to have you expand on that in the future as well if we cut you a little short, so I'm sorry. Ms. Stanton, boy, as always, we covered a lot of ground here, but we should probably have a little capture as far as what we're going to delve on further and what we want to come back, because I expect Chairman Deeds is going to be asking for some recommendations from us rather quickly. So your thoughts on what you heard and a way forward, ma'am. You always get the easy part. Just rewrite, mandatory outpatient treatment. Get back to us, ma'am.
We've got this. We've got this. You'll get the bill for my hours shortly. No, this is, we've got a lot of ground we covered, as you said, and Sabrina and I will actually have a planning meeting following this meeting to work out what exactly it is we need to do and develop a detailed work plan for how to answer the questions from yesterday and today, what we need to do on those fronts. Looking at the meeting, it sounds like there are a couple topics you might want to have information at your next meeting, some things we might want to explore more fully. Some of the things I noted is that we might want to look into COPN and licensing conditions. You raised that question, and I have some ideas about how we can collect some information for you on that topic, so we can at least pull together some written information that addresses that question. You've inquired about some information about the breakdown on state hospital census by civil and forensic, and perhaps breaking down the forensic populations more fully, and we can work with DBHDS to get that information for sure. There are some questions around workforce that we want to get some more information on, and those are looking at workforce needs. Who in our workforce is a full-time state employee or an employee of the department versus contract, and pay differentials and pay rates amongst those. And I think we can get that information. It sounds like DBHTS will work with us on that. Another big topic was the question of the CTACs and the regional centers and what those plans might look like and how those might go together and what those might cost. And on
that topic, the report mentions one in Alameda County, which the doctors referenced to me in each conversation. They also referenced one in Raleigh, which, if you present with these signs, you don't even go to an emergency room. You go to this facility first and foremost. I wonder if it would do some good for us to try to just evaluate what does that look like? What do other facilities, with an eye towards possible regional facilities in the hybrid model from the report?
Definitely. Add to our list. I think we can work with DBHDS and see if we can get some information about how other models, similar models, are working in other localities to see if that's something that we can learn some important lessons from. So we'll add that to the list. Sort of surrounding all of these things is a question about what we can do with the American Rescue Plan funding. And I think as we develop some slightly more specific recommendations, my plan is to take those recommendations to some of the experts that we work with that will have money committee staff and others who will have that sort of information and help us figure out what might fit within those funding sources as well. So we can start to figure out what might be appropriate for a special session when that happens. One of the pieces we'll be watching for that obviously is the VMAP funding that we heard about as well. So sure. I think...
Well, I also think that, our goal is to come up with solutions to alleviate the log jam in the emergency rooms. But we keep hearing from, like Mr. Jones, the 72-hour window. Mr. Green just talking about the handoff from the magistrate to a special master and how the hearing would be held. Ms. Mendez is constant being an advocate for making sure it's done properly and legally. We just need to figure out, because we know the stress is being put on the system based on what we have written. So I don't know what we can do about that, but we ought to at least see where they are and try to do what we can to, in the bigger picture, short term, to see what we can do to help folks that are find themselves in a bad situation.
Yes, we will continue to delve into that. I think for our next meeting, if we can get the specifics on some of these pieces we've talked about around the CTACs, the regional centers, some of these other pieces, and what the funding needs are, we can look at those for possible recommendations at our next meeting as well, hoping to come out of our next meeting with some recommendations that this group might like to put forward to the
Excellent. Now, so before we go to that scheduling, Delegate Ranson, Hope, Watts, anything that we missed there with that capture and our takeaways and things that we need to focus on between now and the next meeting.
Mr.
Yes,
Chair.
ma'am. Ms. Delegate Watts.
Yeah, I would just ask tentatively the subcommittee that I chair, which is called Special Populations, but which grew out of all of the court involvement and law enforcement involvement that might bring people into the systems. Tentatively, we are meeting the third week of this month, so that I would like to have the breakout that you requested as far as those that are being held civilly versus those that are being held for court assessment. Focus on that in that committee. I bring this up at this point also just because there are so many great advocates that are present at this meeting, and I wanted them to be aware that we will be getting into that in our meeting.
Understood. And who serves on that subcommittee, ma'am?
At the, Rob Bell. I'm sorry, I'm missing Thea Price, and I'm sorry, I'm just blocking on the other individual. Okay. Obviously, just like I sit in on your committee, I would really welcome your background on this, and we will be talking.
Yes, ma'am. Okay, so, MJ, I'm sorry.
My apologies. I was going to say Delegate Bell, Delegate Price, and Delegate Ranson are on that committee.
All right. Delegate Ranson doing double duty. That's what I like to hear.
That's why I hesitated. I knew I was going to say Ranson, but I'm thinking, no, she's on this committee. Couldn't be both, but thank you.
So last time I started to break some rules as far as when we could and could not meet. So when can we meet, and how soon can we meet, and when should we meet again? Either Michael or Ms.
Yes, sir. Senator, so the rule is the first and third full weeks of the month can be scheduled without approval from the Rules Committee. Outside of that, if you have dates that you would like to have a meeting on, we just have to seek approval from them.
Well, we ought to. And Delegate Watts, you said your meeting was the third week. What meeting? What day?
Tentatively, I do not see a Delegate Price's attendance at this time, and was hoping I could work out something before I gave a definitive date.
Okay, and so I guess that leaves us to maybe the first weekend. Oh, go ahead, Sarah. I'm sorry.
I was just going to say, if it's easier, what we could do also is we could have MJ, if you want to send out a polling after this meeting or tomorrow, we can just go ahead and poll the third week of June, the first week of July. I will note that the first week of July is traditionally very challenging because we're looking at the 7th. So that is sometimes a problem. But we can poll those 2 weeks, and if we can't find something easily within there, we can look at expanding beyond those if we can get permission from rules. But we can just go ahead and send the polling out now to all members and see what we come up with. That may be the easiest way to handle it.
Excellent. Okay, so my apologies for keeping us a little over time, but we had a lot of information. Delegate Hope.
Mr. Chairman, I only asked a question about timing because if we want to try to get before the governor's office and appropriations and finance on terms of what our priorities are, I presume that the Uber Commission will be making some recommendations relatively soon. Sarah, I don't know if you're aware of that, but we sooner rather than later need to prioritize what we would like to see coming out of these issues. And my preference would be the private bed hospital issue, and to the extent the salaries to try to prop up the department and their needs, and that they have in staffing issues would be my top two, at least coming out of this work group. But there may be others that people want to add to that mix. But I think we should do that sooner rather than later.
MJ, do we have a target for when the full commission is going to meet to make? We do not. Okay. So I figured that would be mid to later July in advance of us going in August.
Yes, Mr. Chair, I would expect that if we are looking at an August special session, we would probably want the joint subcommittee to meet mid-July to that third week of July, so we could have everything. So it sounds like the most appropriate timing for this subcommittee would be 2 weeks from now, the third week of June, if we can fit that in. If not, we'll find a date that is close to that to give us enough time to work through the details.
Mr. Chairman,
Delegate.
I know we've been on here for a long time, but I'm with Delegate Hope. I think that we should really start beginning to narrow down the priorities and prepare for the full commission meeting with, what we want to deliver on the table to them.
I agree. And I like the staffing needs at the hospital. I kind of lean towards more CTAC expansion or something that comes out of that report. But I think you're right. When we meet next, we need to say, we as a team need to go back to the commission and suggest that, particularly with one-time monies, we can make the most dent with this type of focus in the short term. So, and some of the stuff that we'll be collecting from Commissioner Land, I think will help on that. And hopefully the contract money we're already paying out will help make our case for some significant increase in pay for staff. So, okay. Anything else? Anyone else? Again, my apologies for pushing this 15, 20 minutes beyond what we had, but thank you all for all your input, for all the great presentations, and for all the robust discussion on this important topic. So that's it. We're adjourned. Everybody have a great day.
Thank you.